Next item is the Sobering Center's presentation by Laura Elmore, Executive Director of the Sobering Center.
It's on now. Good afternoon. Thank you for inviting me. I think the invitation was mostly to do an update, but I think that there's also some commissioners that I don't know. So I'm going to give kind of some context because I think we're probably a little bit on the outskirts of what you normally hear about. We have incredible relationships with APD and EMS, but we're also kind of a separate entity from the city. And so we have a large contract with the city, but we're not part of the city. So I think that sometimes we get kind of forgotten in that, a little bit of a falling through the cracks. So, oh, I have the clicker, right? Okay. Okay, so what is our mission? Our mission is to enhance both public health and public safety. This comes up a lot, whether or not we're public health or public safety, and I would say we're both. Our job is to provide a place for people who are publicly intoxicated to sober up as an alternative to jail or the emergency room. And then where appropriate to try to connect them to some kind of longer term care. We were founded in 2018, so we're actually pretty new. And we have evolved our model quite a bit, which I'm going to tell you about. Since we opened in 2018, we've done more than 16,000 intakes. May of 2026 was our highest number of intakes ever in the history of the agency, which was 325 in a month, which is a lot for us. That's more than 10 a day. When we intake somebody too, we are kind of with them for quite a long time, right? So it's not just an intake, it's an admission, which sometimes is a short stay and sometimes is a very long stay. So it kind of depends on what's going on. I'll tell you guys a little bit more about that. There's a few photos up there so you can kind of see where we're located at 12th and Sabine. That's our intake room and a little bit of our dorm. Whoops. Okay, so quick reminder, this is a diversion program. So the point is that our main referral partners being APD and EMS can use us instead of the jail or the ER. The idea is that it's supposed to be a time saver for them. It's supposed to be able to refocus them on things that are a little bit more grave than public intoxication. So we are a diversion program. That person, when they come to us, is not going to receive a fine or a citation. There's no medical bills. There's no cost associated with the service. It is voluntary. So I think a lot of on-the-ground work is done by the first responders to kind of figure out who's a good fit and who's not, or who's willing to kind of go, right? We are a 24/7 operation. We've been keeping that plane in the air for a long time, so 8 years almost. We are a HIPAA-protected facility, so there's complete confidentiality. Once we admit somebody, nobody gets to know they're there, and we can't give out any information without a release of information or a warrant signed by a judge. Our goal at that point, once somebody is safely sobered, is to have them sit down with a counselor or social worker or a peer recovery coach and chat with them about, is this a one-time thing or is this more of a chronic issue? If this is more of a chronic issue, then we want to talk about treatment, long-term placement options. We do try to assist with coordinating them getting home. Maybe that's a safe ride from a family member. Maybe that's an Uber once they've sobered up. But we are very careful about people leaving there in any form of intoxication. Okay, so we are not serving any kids in our facility. You've got to be 18 or up to go. There is a requirement of a suspected alcohol or drug intoxication. That seems obvious, but it's actually kind of hard to know. You don't always know what sometimes might be psychosis, what might be an allergic reaction. There's a lot of reasons why people look to seem on alcohol or drugs, and we don't really necessarily always know. You can do a blood alcohol, content on somebody, but we don't have a lab, and neither do the folks that are the first responders. So we're not really know like what kind of substances are on board, what the person has ingested, if they've been drugged, if how much they've had to drink or use. So when they come in, we're trying to assess that, and we're staffed with medics. Our medics work for the Sobering Center. They don't work for EMS, although I've sort of become a training ground for EMS. I think that anybody going to EMS I'm losing them. So I have to talk to Chief Hopkins on the side about that. But that works out for everybody. I'm hoping that we can turn out some good medics that will actually end up at Austin Travis County EMS. I think that we have a really unique opportunity because we're more of a facility. I refer to us as a stationary ambulance. We share a medical director with EMS right now, so there's a lot of things that we can do in the sobering center with the partnership of EMS that most sobering centers cannot do. So admission criteria, when they come in, they're assessed by a medic. We're checking for head injuries, any open wounds, seizures, any kind of obvious internal bleeding, and suicidal and homicidal ideation. So we're doing a quick scan for, does this person really belong in a hospital and there's no way to divert them from a hospital? Are we able to care for them here with the staffing that we have? So that's how we decide on who is admitted. Our rate, I just looked at the data for this past month, our non-admit rate was 8% this month. So there is like a section of people who will get to our door and not make it in, and that's because either there's a behavioral problem in triage where APD has said, nope, this isn't going to work, or there is a medical issue, and the primary non-admits are going to be medical because we're having to transfer them to the hospital for further evaluation. So sometimes we'll transfer them over to the Del Seaton emergency room. They'll get evaluated by a doctor, and then they can even return them to the sobering center so they're not taking up an ER bed. So this is our process of care. The client is transported to us by usually law enforcement or EMS. Those are our top two referral partners right behind each other in terms of numbers. Right after that is the Del Seaton emergency room. Right after that is Integral Care's psychiatric emergency services. Those dynamics have changed significantly. The numbers in terms of our referral partners. A huge change that we made when I came onto the sobering center in 2020, one of the first things that we changed was, do we always have to have licensed sirens to get to the sobering center, or could there be other referral pathways? So still we want to be a primary source for APD and EMS, but now we also have almost 100 other referral partners. That would include Capital Metro. That would include the Austin Public Library. That would include other hospitals in the area. That would include Integral Care, psychiatric emergency services. That would include sober houses, treatment centers, lots of community-based nonprofits, Safe Alliance, LifeWorks, places where somebody might show up publicly intoxicated. We want to try to avoid calling 911 if we can, to save their time, but also to not escalate the situation in an unnecessary way. So once they get to us, by whatever referral partner they get to us, the intake medics do a screening. We decide whether it's safe for them to stay. They come in, we monitor them for their safe sobering. Those monitor folks are techs usually. Usually we have about 3 medics on a shift, and then we'll also have either peer support specialist or a social worker or somebody in those roles. And then our expert counselors or social workers will conduct that assessment I mentioned to figure out, is this a bad wedding experience, or is this a chronic addiction, like living on the streets type of issue that needs to be addressed with longer term care? In terms of a bad night, we definitely see that. We have college students, we have tourists, we have partiers, we have festival goers, and then we have people who've lived on the street for 25 years and have an ongoing addiction and a ton of healthcare problems, and we see both. So those counselors are there to figure out which one is which, or is it somewhere in between, and then what are our next steps to get them an appropriate level of care. We founded in 2018. We were founded through an agreement between the city and the county. So like I said, we are a 501c3 nonprofit organization. We're a separate entity from the city and the county. However, the agreement states that the county will provide the facilities, which is the former medical examiner's office at 12th and Sabine. And then the city would provide the operational funds. So we have a large contract with the city for the operational staffing, and then the county provides the building. We renewed that ILA in 2024. It was a 5-year agreement, and then I had to go present to city council an outcomes analysis, a cost-benefit analysis, and then they renewed the interlocal agreement with the county in 2024. How's it going? So law enforcement and EMS are no longer the only paths that I mentioned. We have many, many other referral partners. Patients are now able to hold over for services. This is something we created in 2021. What that means is that you typically would come sober up and leave in about 6 to 8 hours in the old model of the sobering center. In 2021, we had a patient picked up by EMS 75 times in 135 days. One patient. I bet you Chief Hopkins could tell you how much that costs. It's a lot. It's a lot. So one guy that everybody knew who he was, right? Because sometimes he was stealing wine from the 7-Eleven, he would go to jail. Sometimes he was unconscious on a park bench, he had to go to a hospital. Sometimes he was publicly intoxicated, but lucid enough to come to us. We saw him easily a dozen times before he would even talk to us. He would pass out, sleep it off, get up, go out and drink. Something I think the public does not understand is that you can die from alcohol withdrawal. You're not going to die from meth withdrawal. You're not going to die from crack, even though those things are very illegal and very scary. Alcohol is an incredibly toxic substance. So he was to the point of so physically addicted that if he didn't go out and drink, he was going to get sick or have a seizure or die. So that summer, he probably at the end of, I don't know, a dozen visits to us, said, okay, I'm ready now to go to detox. Has to go to a medical detox. There's not an option for him not to go to medical detox. But there is no such thing. If you are indigent or homeless or have no insurance, you cannot access medical detox on a Sunday morning at 8 a.m. It's not a thing. It doesn't exist. So what we did was we held him at the Sobering Center for 5 days. We had never done that before. We are not a licensed residential treatment facility. We are not a detox. We don't have a kitchen. We fed him Ensure shakes and pretzels for 5 days, and our medics monitored him every 15 minutes for 5 days. And then we put him on a bus to Tyler because that's where the treatment beds were. He came back here 90 days sober, like a different human being, and we were like, oh, okay. So probably we should try to do that as much as possible. We're going to do 3,000 intakes in a year. We're probably not going to get 3,000 people into treatment, but we are going to get about 250 people into treatment, and that's a huge deal given that the number of treatment beds are disappearing in Texas. Nonprofit treatment centers are going out of business all over the state. So if you don't have money, treatment is just really not an option. So we are continuing to treat addiction, which is a chronic long-term illness, with an emergency room model. And really, a lot of the treatment is being done by EMS. That's what you're seeing with the BUP stuff. That's what you're seeing with every creative thing that EMS is doing is addressing that because there is no other option except people to die from addiction on the street. Bridge Meds is a great example of that. That's a partnership we created with EMS. What that means is that we are not a detox. However, if we can get a doc to write a prescription for Librium, then we can monitor them and they can do a step down on Librium in the Sobering Center. If there is, occasionally we will have the CHIP medics from EMS come in and do BUP in our Sobering Center. So we have the facility, which is safe and clean and has, medics to monitor. So sometimes CHIP is looking to induct onto BUP, but this patient is like, I would like to leave this homeless camp, but I don't have anywhere to go. Let's bring him to the Sobering Center, and then we work with CHIP like that. We also do have CHIP come out and do the assessment to start Librium. So we have quite an amazing and innovative partnership with EMS that is actually a nationally recognized partnership that most sobering centers do not have. So I'm pretty proud of that. The Bridge Meds thing it's a duct tape solution. And I actually think that question that came up earlier about MAT and buprenorphine, it may be from Tim, was that I bet that's part of that is you might be doing BUP in the woods, right? Or like on the street in an alleyway. And then going into actual MAT treatment would require them actually engaging with a clinic and having a doctor and doing long-term care. That's how I would interpret that data as just a total bystander. I have no idea if that's correct. But what I've seen on the ground is that you're doing a lot of on the fly, on the ground, in the streets, trying to get people off of opiates onto some other substance that is medication-assisted treatment. But a long-term treatment, either in intensive outpatient or residential, are so hard to come by that it's almost impossible to connect people who are homeless to something like that. So our connections to treatment, and I would bet EMS's CHIP connections to treatment are actually pretty small numbers because we don't really have the infrastructure for it here. So what's next for us is that we have renovated the building. We decided that, it's probably been a year since I've been here. We decided that the building wasn't really being utilized well. It's 3 stories. It's the old morgue. It's probably haunted. And so the host team was on the 3rd floor, the homeless outreach street team. They moved to where the downtown Austin Community Court is. So we moved our administrative staff up to the 3rd floor, and then we renovated the whole 2nd floor for our holdover program. So that's for people who need treatment, want treatment, have nowhere to go, have no way to pay for it. Instead of us like trying to duct tape it together, we created a second floor with 14 beds. The county funded that entire thing, about $1 million worth of renovating the building, setting it up. Central Health is paying for the operating funds on that second floor. So we are just now getting it open. We're almost finished staffing it. And we're currently bringing our holdovers upstairs during the day to do programming, and then they sleep downstairs where we have full 24/7 operations. Upstairs, though, we have natural light coming in, we have plants in the windows, they have privacy, they have a curtain, they have a storage thing, they have their own bed, so it's not like as much of a crisis stabilization unit as the first floor. So that is about to be, any day now, fully operational and will double the capacity of the center. A couple things that haven't done a lot of talking about publicly, but I want to make sure that you guys know because of your role. The Office of the Chief Medical Officer for the city, Dr. Escott, has informed me that they do not want to serve as our medical director anymore and that we need to find a new medical director. So I am hustling on that. It is not an easy thing to find. It's a 24/7 deal. So currently we have our on-call we're doing with EMS or with ACMO. So we're working on that, trying to find that solution, and pretty soon we'll be transitioning medical directors. That's maybe important to this commission. And then the other thing is Commissioner Bernhardt mentioned earlier Central Health kind of coming in to pick up some costs on things. We have a contract with Central Health we've had for a couple of years now where they are paying for any of their patients who are in our facility for more than 24 hours. They come in as a payer for that person. That person is staying 5 days, 7 days until we can find them a treatment option. They're paying for that. They're also starting to get into the business of contracting to pay for treatment beds, which they have never done before. That's taken years and years of advocacy to get to that point. But they're here now. So we have been approached by Central Health for them to basically make the Sobering Center a part of Central Health, which would change entirely our relationship with the city. That is a very, very early dialogue happening at the both boards level. Both of those entities are local government corporations. Both have boards appointed by the City Council and the Commissioners Court. So I don't have a ton of answers about that in terms of timeline, but it's moving. The most important thing for you guys to know about that, which I'm thinking that might be important related to budget, is that we just have to have our budget level. We don't need more money. We're not asking for anything. We're not expanding any programs. The City Council has repeatedly asked, why isn't Central Health paying for this? This is a healthcare service. It's always been a healthcare service because we've always had medics staffing it and we've always had a medical director. And when you're talking about especially alcohol withdrawal, you're talking about a medical crisis. However, the more we evolve the model to meet community need, the more it looks like a healthcare service, the more it looks like treatment. And it's heading in that direction. Central Health is interested in building a treatment center, a detox, a continuum of care, and they want the Sobering Center to be part of that continuum, which delights me to know it. So I'm thrilled about it. But in terms of budget, I don't think that's going to happen before budget. I think we're going to have to just stay with the city for one more fiscal year. But what I'm hoping is if the city manager's office can see that there's a light at the end of the tunnel, this piece is going to go away off of the city budget, that they just don't mess with it. And that's kind of all I'm asking at this point. Is just leave it level so we can manage the transition, because it will be a huge project. And just, I mentioned this earlier, but I'm the chair of the board of the National Sobering Collaborative, which is a group of sobering centers across the country looking at best practices and standards of care. We were part of the International Association of Chiefs of Police toolkit on how to use sobering centers, and Austin was highlighted as a case study on that. And like I said, people ask me all over the country, especially about our relationship with EMS. How did you get that? How did you do that? Luckily, I didn't. I inherited it. EMS has been at the table from the beginning as a partner, as a donor of supplies, and just in and out. We're just cross-referring all the time. So we are well known for that across the country. And tomorrow, the whole city of Nashville is coming to see our sobering center because they want a sobering center just like ours. So I'm pretty excited about that. This is just a little snapshot of our strategic plan. This used to be like hot off the presses information because it was a 5-year strategic plan, and now it's almost 2027. So we're almost finished with all of these goals now, and I kind of already covered those things. So let me open it up to questions.
Phenomenal presentation,
Thank
Ms.
you.
Elmore. I'm very impressed with what the work you're doing and the alternative to jail time. The story you told about you helping that person for 5 days, you're doing the Lord's work, and I appreciate y'all for doing that. I am glad that there's renovation projects going on. Like, I don't want to see y'all move to Bastrop, as we're hearing. Sorry, Chief, couldn't help that, but I know you won't it, but just thank
We're
you
not
for
going
that.
very far from the Travis County Jail, so
Yeah.
I don't think we're moving into Bastrop.
That's all I have. Commissioners, questions, comments?
I have a question. I don't, is the desire for ACMO to no longer be medical director, is that driven by finances?
It's their desire, not mine.
Okay.
My understanding is it's driven by capacity for
Capacity.
the number of doctors, on-call doctors.
Okay.
Yeah. And the fact that the evolution of the model looks less and less like an ambulance, right? So it's a different scope. You could probably make an argument either way, but that is what I'm being told.
Okay. Thank you.
Anything else, Commissioners? Commissioner Smith?
I'm wondering if we have publicly available data related to the demographics of individuals that were served by the sobering center versus those who got the holdover programs versus those who weren't able to enter the doors, and where exactly that lives.
We send all of our demographic data to the city every quarter because we have a contract that looks kind of like a social service contract, although it's a different bucket than the social service contracts typically. But yeah, we do have that data. I can tell you the demographics off the top of my head. I couldn't break it down by safe sobering versus holdovers versus non-admits, but we look at a pie chart of the demographics from from race and ethnicity to gender to age to kind of all of those pieces in somewhat by zip code, although it's very unreliable data because everyone is very intoxicated in terms of like, where do they live, right? So it's easier for us to say homeless or not homeless than it is for us to say this zip code or that zip code. But we tend to serve, like in terms of race and ethnicity, we tend to serve something that looks very similar to the population of Austin, although slightly elevated groups with people of color. So we're serving about 33 to 35% Latino and about 15% Black or African American. And then the rest really identify as Caucasian. Gender-wise, it almost never changes. It's almost exactly 75% men always since we opened. It's almost always been like that. I have lots of theories about all of those things, about why men versus women, right? Why substance of choice over not. We see so much more alcohol and meth and stimulants like cocaine and crack than we see opiates. And that's not because opiates is not a problem in this community. It's because opiates is a more privately intoxicating substance, right? So you're not likely to get the attention of APD at a party with opiates. You're more likely to be alone or isolated or, something like that. So I think there's a lot of room to even talk about, should we be doing more for people who are sort of privately intoxicated than publicly intoxicated? Because you can also take a lot of risks in certain demographic groups to be publicly intoxicated, right? That you can't take in other demographic groups. But yeah, all that data exists with, our contract management has changed. It was Austin Public Health, then it was EMS. Now it's Downtown Austin Community Court. So they have all of that data, but we also have that data. So if there's specific like timeframes you want or breakdowns by the programs, I can figure that out. I don't know that we'll have the demographics of non-admits because they leave and we can't also always get the demographic data, but I do have non-admit data by why they didn't admit. And then I do also have an outside researcher came in and looked at some of our outcomes and put kind of an equity lens over it to kind of see like people who are leaving against staff advice, you know, are those people more likely to be from this racial group or this gender group or this age group? So we have some of that data as well. And not all of it is in our control because we wait for a referral from the outside, right? But we wanted to see like, are patients being treated equitably once they're in our center? Once they've admitted, you know, we can't control what the referral partners decide in terms of are they taken into jail or the hospital, but once they get to us, do they have similar outcomes in terms of like who gets to stay if they want to stay and who leaves against staff advice? So we do have a pretty detailed report around that as well. If y'all are interested, I can definitely send all that over.
I would love to see that.
Yes.
That sounds like such interesting data. And these like underlining assumptions or possible like metrics or methodology, should I say, that we could be using to solve the issue. I think you have some really cool data. And I would love, I would rather not, I mean, commissioners, if you guys have something specific, obviously throw it in, but I would rather not close your universe. I'd rather you give me the full report. And then next time you come back to something you found really interesting. Like, hey, I saw this trend of, you know, this specific demographic during this time. And this is what I think this, you know, I would just like to hear your expertise in relation to kind of what that data could be telling us about how we could be even better all-stars in this space. Let's get to the peer-reviewed article space as well, because we are creating something that is, you know, pretty magnificent.
Yeah, I am a total nerd for it. I will send you some stuff that I have, and it's pretty dense stuff that we could dig into, you know, but yeah, I'm happy to do that. And we also have, via our connection with the National Sobering Collaborative, there's a researcher that is an expert in this area that has put in a proposal to the Arnold Foundation in Houston, which is now called Arnold Ventures, I think, which has passed the initial funding stage, and we would be included as one of those evaluation sites. And it would be specific to some hospital outcomes and EMS outcomes, because the National Sobering Collaborative is really trying to get other cities' EMS systems to participate the way that they participate here. Part of the issue is a reimbursement issue. They don't get paid to bring to us. They get paid to bring to a hospital. Right. So our EMS system is just one of the most progressive in the country, and they just have been at the table with us as a partner from the beginning. And I think there might have even been initial grant funding for this project, but I don't think there is anymore. It's just, we're just here. We're at the table, and it's just part of like what obviously makes sense for the patient, right? But that's not true across the country. And there's lots of states working on legislation around it because there's ordinances and there's rules about who you can hand off to. Like the medics have to hand off to a medic. They can't hand off to a peer coach. And so that's the whole point of what I was saying earlier about, well, we are a healthcare service. We always have been the way EMS is, because we have to take EMS referrals or to do hospital diversion, we have to be a healthcare service of some kind. Anyway, I digress. I will send you some nerd stuff.
Commissioner Ken.
Two questions, one short-term, one longer-term. So short-term in terms of the budgetary components, do you have any sense for how likely it is that, or how receptive city staff is to maintaining funding at a baseline level?
I am being told that they are going to just copy paste from last year's budget to this year's budget. I have never had this happen. You know the history of it. There has always been an issue where our budget ends up cut and goes back to some old number from an old spreadsheet from like 2016. And then I have to go to council to amend the budget every single year. I've never not been to council with this budget. This year, the assistant city manager said, that's not going to happen. Your budget's going to be in the draft city manager's budget. So I just have to take her word for it at this point, and hope that it's there in July. And if not, then you'll probably see me at council trying to make that money level. Because I just don't want it disrupted. I really can't do the disruption while we're trying to do something like a merger of a major organization.
Sure. And if you could send us any of those past details just so we can have those and advocate on that end, that would be useful. And the second question, longer term, I know this is on your radar, but just thinking through if there is more merger with integral health, or central health, making sure that that doesn't lose the benefits of the close integration with EMS and some of that first responder that I think has really been one of the very successful things.
Yeah.
And balancing that sort of short-term health versus long-term health care. And I'd be interested in hearing down the road as you pursue that more, just making sure that we can maintain what we're doing that's excellent, as well as build on what you guys want to do and need to do.
Yeah, that was a huge part of the conversation. Is it's a huge deal breaker if the first responders can't use the sobering center. Like, what would be the point of it, right? It's not just a place to show up. It's like it's meant to be part of a collaborative relationship with the city. So, and part of Central Health's statute states how they can spend their money, and they have to spend their money on indigent healthcare. They can't spend it on just everything, right? That's part of why, to integrate with Central Health, we would have to become a program of Central Health, because if we're directly the provider, then we can open to the public, which means serving whoever APD and EMS decide they want to bring to us, versus doing a MAP eligibility or something in the back of an ambulance, which is like obviously not doable. So that was a huge part of the beginning of that conversation, was like, this can't work unless we have the same kind of relationship with EMS and APD that we have now. Obviously, we're going to have a medical director transition. I think that's going to change things a little bit, but hopefully not significantly on the ground.
Any additional questions? Oh, Vice Chair.
Just a quick follow-up question. Will the transition to Central Health impact cost for the city for use of the sobering center?
That has not been determined.
Okay.
It's possible that they will try to negotiate something where the city would put something in for the cost, to use it,
Yeah.
or have the first responders use it, because we have documented cost benefit analysis to it. So it definitely saves the community dollars. It saves the city. It saves the county in terms of jail beds. It saves the hospitals quite a bit of money too. So that's part of why Central Health is being brought into the table. But maybe the city will have some kind of financial part to it, but it would go like to Central Health directly. It wouldn't be like me trying to advocate for the full budget to be part of the city. So it would definitely be a huge cost savings to the city to move forward with the Central Health partnership.
Thank you.
Any additional questions or comments? Okay. Thank you very much. Keep up
you.
the amazing work.
Thank you so much.